Welcome to this launch of Responding to the Death by Suicide of a Colleague in Primary Care, a Postvention Framework. I'm Nick Parle from the Society of Occupational Medicine, Chief Executive. Really pleased to be hosting this with the Louise Tebboth Foundation, who've been instrumental in producing this report that's been written by Gail Kinman. I just want to do a few introductions, and then I'll hand over to Alex Freeman, who's the chair of the Louise Tebboth Foundation. Firstly, I want to acknowledge Gary Marson, who's the secretary and founder of the Louise Tebboth Foundation, and also the great work of Dr. Rebecca Torrey, who's a trustee, and she'll be speaking after Alex. Now, Louise Tebboth Foundation have got two excellent patrons. Their biographies, along with Alex and Rebecca's, are in the pack that you've been sent. So they have Sir David Haslam, who'll be speaking on the wider perspective, and at the end of the session this afternoon at 4:50, Baroness Laura Finlay of Landruff is going to ask for some reflections, or put her reflections forward. You should have received, as participants, a copy of the report itself, and also a press release that we sent out to contacts today. And thanks to Anne Caliori, who's helped with that, and also Nick Llewellyn, who's in the background helping everyone with their technology from the Society. I want to particularly welcome NHS Practitioner Health, obviously a big part of the solution. We're hoping Dr. Claire Gerarda will join us, but Lucy Warner, who's the lead for NHS Practitioner Health, will be speaking of that later too at 4:20. We've also got, very pleased we've got some responses from key institutions, and welcome to Martin Marshall, who's chair of the Royal College of GPs, and his colleague Pauline Form, who's medical director for RCGP Primary Care Development. So welcome Martin and Pauline, and hope to get your feedback later on, along with David Wrigley, who's the British Medical Association Deputy Chair and Chief Officer. Welcome to Martin and David. I do suggest that when you're doing, having a look at this afternoon's session, that you set your Zoom to speaker view, and then you get particularly a good view of the slides, but also there's a fantastic video at the end, which at 4:55, which I really encourage you to stay into the end. It's very powerful. I mean, clearly this is a serious session. We're dealing with a very important issue. If you're finding it personally difficult, have a look at the report. It's got some great resources there. You know, look after yourself, you know, if it's upsetting, and there's resources there for Mind and Samaritans, etc. So that's enough from me. I'll be taking you through, and there'll be an opportunity for you to clarify in the chat, and there'll be also discussion at 4:35 with the panel, so you can ask questions then, but I'll be looking at the chat in some detail. So do put any comments in there, and I'll try and bring them in. But and now we're going to move to a kind of three presentations, short presentations for 5 minutes only. Firstly from Dr. Alex Freeman on why the study was commissioned. Next, Dr. Rebecca Torrey about the impact. And finally, Sir David Haslam's going to talk about the wider perspective, and then it'll be back to me to introduce the paper author, Professor Gail Kinman. So I'll put myself on mute. Zoom, make sure you're on mute if you're not speaking, and hand over to Alex Freeman. Over to you, Alex.
Thank you, Nick. Whenever I talk to people about death by suicide in the medical profession, there's two questions that often get asked. Just how many doctors do die by suicide each year, and how do people cope with the aftermath? The answer to the first question is difficult because we don't have any system of real-time monitoring, and therefore we have to be reliant upon historical data, such as that produced by the Office of National Statistics. What we do know is that the mental well-being in the caring professions is deteriorating as a whole, and therefore the risk of suicide must inevitably increase. The answer to the second question is much more complex. Louise Tebboth was 40 years old when she died. Her medical history, her age, her gender, and her specialty automatically put her into a high-risk category of an already high-risk profession. We're very good about talking about statistics and quoting figures and risk factors in a detached way. But what we must always remember is that behind these statistics are real people. So let's stop quoting statistics. Let us start and continue talking about real people. Suicide must never be a taboo subject for the medical profession. For as long as we keep talking about it, we acknowledge it, and we can take the next steps to address it. Louise was a wife, a daughter, a sister, a friend, a professional colleague, and a GP to so many individuals, all of whom had to come to terms with her death in their own ways and at their own pace. 2 years ago, we published the report, What Would Make a Difference to the Mental Health of UK Doctors? A review of the research evidence. This report has been cited in many publications and other reports, and including those produced by the British Medical Association and the General Medical Council. The authors of that report, Gail Kinman and Kevin Teo, are with us today, and we'll be hearing from Gail a little later on this new report. It's therefore natural that when we were looking into another aspect of doctor suicide that we would approach Gail again. For us at the Louise Tebboth Foundation, our aims are around the mental well-being of doctors, but also supporting those who are left behind. One aspect which did not appear to have been covered in the literature was what happens following the death by suicide of a member of the practice team. A good general practice, regardless of size, often refers to itself as an extended family, and who are no less affected by the death and have the added complexity of a population of patients who've also been impacted. Just how do they cope? What support is needed and when? And how can they access support at the right time? What was really revealed in the interviews conducted as part of this study is how difficult it was to access the right kind of support or even know what kind of support would or should be available to them. One of our interviewees described this as a major incident for which all practices should have a plan. We hope that this report will help others when the unthinkable happens, and will also assist policymakers, commissioners, representative and supporting organisations in planning the kind of support that they could and should be offering. Rebecca.
Thank you, Alex, and thank you everyone for joining us. When we talked to people for this study, they spoke of losing their colleague as if it was yesterday, even if it was several years ago. Louise Tebboth was my friend and practice colleague. I was at her wedding. We travelled together to see a friend in Central Asia, do some health promotion sessions in a clinic between the city and the mountains. The Saturday I learned of her death is etched in my memory, as I'm sure it is in the memories of others from my practice, some of whom are here today. There was the early morning phone call from Gary, her husband, telephoning my partners and sensing the almost physical blow they experienced when I broke the news. The practice planning day, which was totally changed. Working out who would ring which staff to be sure they knew before Monday morning. Coming in early on the Monday morning to meet everyone at the beginning of the day and again at lunchtime. At least there were 5 of us to sit in stunned silence together and begin to talk and try and plan. We didn't always agree. We got some things wrong for ourselves and for our colleagues, but we tried to support each other through it. We're about to hear from a doctor who was one of only 2 partners. She was doing non-clinical work in the practice one morning when her partner didn't come in to do his booked surgery. This was totally uncharacteristic. After half an hour, she became worried and went to his flat. There was no answer. Eventually, she and the police broke in, and it was clear that her partner had died by suicide. No one should be left to cope alone to the extent that she was. As a caring profession, we should be able to do better for each other. Let us listen to a little of what it was like. And I'm sorry it's not entirely a perfect recording, but it was a real recording.
I just sat there and cried for about half an hour, and then the police wanted to take a statement from me. They took a statement from me. I called the practice. my practice manager was really sweet. She sort of told everybody, and she took charge. I said, I'll have to finish surgery. Could you have a surgery book? And the way you think of doctors, I said, I better come and do surgery. She said, no, you're not going to come and do surgery. I'm going to cancel all these patients, and anybody who needs to go for an emergency today will go for an emergency. We will have to do this. It was really helpful. She took charge there. Then what happened? So I had to just get to sort the surgery out. So the next day, again, my practice manager said, you're not seeing any patients, but there was all the prescriptions to do. Locums don't do prescriptions. So
she had got a locum in.
She managed to get a locum in. Yeah, she managed to get a locum in. And I think that was my hardest day. It took me to do 10 prescriptions, but I think it took me an hour, and I knew I wasn't thinking properly. So at least I had the presence of mind to work slowly, because I was actually, just looking at the prescription, thinking, what am I actually prescribing here? What am I prescribing? So I took my time with it, and I did it. I wouldn't wish that upon anybody. I wouldn't wish it upon anybody. So the other thing that was learning that I found really hard was that I didn't know who to tell, what to tell. So I didn't know the procedures. I've never had a death. So CCD were absolutely useless. I mean, maybe they didn't know. I mean, it's not that they're useless. I guess nobody knows these things, so didn't have any contact Friday. Then Sunday night, I wanted to let my when we were PCTs, we had a medical director, and she was like, oh my God, are you all right? And I said, well, no, not really. And she said, but have you done anything? And I said, I don't know what you mean. She said, but you need to tell your medical director. And I said, I don't even know who our medical director is. And so she helped me. I mean, if I could help anybody, I would say, I'll write you a list for the things that, you can do. She dropped everything and came there, so she was really good. And she called LMC support unit for me. I was referred to the practitioner health program. I went to see the practitioner health program. I saw a mental health nurse. And he said, well, I think you'll go for bereavement, and I think you're quite resilient. I think you're okay. And I said, yeah, I think I'm okay. I mean, I'm going to feel rubbish. Partner's died. I never saw him again. I didn't feel I needed any more. I made an appointment with my own GP, and I said, I'm all right. I'm okay. I'm just here because I thought I should be here. So he gave me a medical certificate. And of course, Rebecca, if you're the only single-handed GP, who do you give your certificate to? I'm giving it to myself. The work needs to be done. Nobody's doing prescriptions. Nobody's doing anything. So I just tore up my certificate.
How on earth do you follow that? That's left me with just so much to think about. Alex Freeman earlier on described Louise Tebboth as being a member of the caring professions. And I'm just double checking that I'm not on mute, which apparently I'm not, so that's good news. Caring professions is a phrase, it's almost a cliche that's traditionally been used to describe a job that involves taking care of other people with the essence of real concern for human beings. I've always thought that was just too shallow a use of the term. Doctors and nurses and other clinicians care in so many ways. They care about the quality of care they give. Part of the reason that doctors get so upset about complaints, for instance, is they really do care. Unlike some other professions, they struggle to shrug things off. We care about our patients. We care about the quality of care we offer. And we care about our colleagues, which is why the sudden death of any work colleague can be so overwhelmingly shocking, distressing, destabilizing. I think we've seen during the opening phase of the COVID-19 pandemic, the immense distress, not to mention fear and anxiety experienced by the colleagues of those in our profession who've lost their lives to the coronavirus. And emotions can be immensely complicated, not just sadness, but guilt as well. Guilt, we might have done more to help. Guilt that it was them, not me. Guilt and sadness and overwhelming distress. And when the cause of death in a colleague is suicide, these feelings can be even more overwhelming. Feelings really, really matter. For too many of us, from our earliest days in medical school, we're almost taught to suppress our emotions and our feelings. A gradual and often apparently necessary desensitization begins to protect us, that gallows humor perhaps. an ability to shrug off the awful physical and emotional events that may face us any day. But when a colleague, who may also be a friend, someone who you've worked with for years, dies through suicide, then the emotions we feel can be totally overwhelming, enough to break through the hardest of protective shells that we may have developed during our careers. And so I'm really delighted this report's been produced, though deeply saddened that it's necessary. It's packed with timely, focused, clear and logical advice and support, and completely recognises the immensely powerful emotions that the death of a colleague through suicide may trigger, and that these may have a profound impact for a very long time. After all, general practices often have small, stable teams, and those who work in the practice will have often cultivated close working relationships and personal friendships. Perhaps the key paragraph for me in the report was this one about external organisations like CCGs and LMCs and others. I quote, "Although it might be assumed that these bodies would be able to provide practical guidance and other types of support, our interviewees expressed frustration and concern at the reluctance of anyone to take responsibility or offer assistance." And it continues, "The bodies that were approached didn't seem to know what to do or what to say, apart from to express sympathy. And this left practices obliged to cope alone, in spite of being very vulnerable." And of course, it's perhaps not inevitable that CCGs prioritise their duty of care for patients, sometimes not even permitting closing the practice for a funeral, for instance. But surely we owe a duty of care to practices too. COVID-19 may have helped highlight this. When the cause of death is obviously very different, the recent tragic spate of deaths of doctors from COVID-19 has shone a really powerful light on the need for support. The cause of death, in that case, may be a virus, but the emotions triggered in colleagues may be equally intense. Guilt that the doctor was exposed to the risk, for instance. It would make absolute sense for support to be made available whenever and wherever there's been a sudden bereavement, whatever the reason. And it might be too much to expect each and every CCG or local area to develop the expertise, which perhaps it makes it more logical for national or regional teams to take this on, to be identifiable and expert sources of guidance and support. We're all members of a caring profession, and that care absolutely needs to extend to our colleagues who find themselves faced with the dreadful challenge of the death of a colleague from any cause, but particularly from suicide. For all my long career in medicine, the medical press has had so many stories, tragic stories of doctors who've taken their own lives, and every time I read them, I've been left with this sense of, what a waste, what a terrible waste. Let's not waste the opportunities this report gives our profession to make a real difference. And so I'm really honoured to pass back to Nick, our chair for the afternoon. Nick.
Thanks very much, David. I agree. What a waste, and tragic, each one. Well said, and also lovely to hear that recording. Thanks, Rebecca and Alex. So I'm going to hand over to Professor Gail Kinneran now, who's going to talk about the report and in detail, and do ask for clarifications in the chat. I can see there's about 50 of you there in the Zoom, so do chat to each other, but also clarify with us. There will be discussion a bit later. So Professor Gail Kinneran, she's worked with the Society of Occupational Medicine and Louise Tebboth Foundation, both on a report on mental health of doctors and for nurses this year, funded by the RCN Foundation. I know she's worked also with other professional groups like social workers and prison officers. She's an occupational health psychologist, a chartered psychologist based at University of London at Birkbeck, and I'm very pleased to introduce her and hear more about the report in detail. Thanks very much.
Thanks very much, Nick. Can I just check with everybody that you can see my slides?
Yeah, that's good.
Thumbs up, everybody. Thank you very much. Right, well, before I start, I would like to express my thanks to the Louise Tebboth Foundation, particularly to Rebecca Torrey, with whom I've been working very closely for several months now, and it's an absolute honour to have been commissioned to do this really, really important, crucial work. Okay, so responding to the death by suicide of a colleague in primary care. I'm just going to be giving you a very brief overview of quite a long document. So, are we moving? Yes, okay. So, as we've heard from the previous speakers, the sudden death of any work colleague can obviously be shocking and distressing for staff members, but also very destabilising for organisations themselves and can have very long-lasting negative effects. But obviously, for a death by suicide, these emotional reactions can be very extreme for well-being and functioning. So it can have very long and wide-ranging consequences over time. And clearly we need a compassionate and supportive approach in order to help people and organisations recover from that. But up until recently, there was very little on offer to help people do this. Most work in the area tends to focus, understandably, on suicide prevention, but there's relatively little around on what can be done in terms of what's called postvention, what can be done following such a tragic event of a death by suicide. So a postvention is defined as the actions taken by an organisation to provide support after the death by suicide in an effective and a sensitive way. And there are 4 key tasks involved in this. Now, firstly, to provide appropriate information. And what often happens under these tragic circumstances is, there's not a lot of information that's actually passed out. So people tend to engage in rumour mills, etc. There may be inaccuracies, and that can be very confusing and sometimes distressing for all. So to ensure that appropriate and timely information is provided. Secondly, to make sure that staff are supported to deal with any grief they may experience and any difficult emotions or trauma. And as we'll see later, the type of emotions that people can experience can be very complex. Thirdly, to stabilise the environment wherever possible and to restore some semblance of order. Now, obviously, this is going to be very challenging, restoring routine, because the organisation will have changed and it may well take time to restore even some semblance of order. And most importantly, I think, in that a death by suicide can often be stigmatised, to work to try to reduce and address and reduce the stigma associated with a death in this way. But what about suicide postvention in primary care? As we've heard from the previous speakers, we do know that healthcare professionals, particularly doctors, particularly GPs, particularly inexperienced GPs, are at higher risk of suicide. And indeed, there are some existing postvention guidelines out there, but very few. And are they relevant for primary care? And as David just mentioned, primary care organisations are very small and self-contained. They don't often have access, if at all, to human resources or in-house counselling, etc. So people working in primary care tend to be have very close, long-standing relationships. So, it may be rather different and their needs are likely to be different. So first of all, the aim really was to develop a postvention framework to support primary healthcare organisations after a colleague's death by suicide. And the method that we used was grounded theory, and we drew on several sources, including interviews, less formal conversations with people who had experienced a death by suicide of a colleague, and also had opinions on the issue. And we reviewed existing postvention guidelines and also potential sources of support that might be useful, like models and frameworks that we wanted to include in the report. And the findings, as I'm going to be just giving a very brief overview of today, we identified key tasks and support needed at very important times. Now, 4 different periods. First of all, the first day, very crucial time, the first week, the first month, and over the longer term. And I'm going to be very briefly taking you through some of the key tasks involved during those times. Okay, so we have the first day. Now, this is obviously a very, very important time. As we can see from the first quote here, there was no pre-warning. It was all very shocking. So, of course, we have a situation where people need to decide how to break the news, and it's clearly very important that all staff members are told, even though they may not be present at the time and not be on shift. So as one of our participants said, we sat in silence for over half an hour, and then we got our pen and our piece of paper out and began to work out how to break the news. And this involved dividing people into groups and ringing up staff members just so they knew and they didn't have to come in the following day. Dealing with the stress of staff as well, and making sure that they have not only time but physical space for mutual support. And clearly it's also very important to ensure that managers are supported. And it seems to me, from listening to a lot of people and from interviewing lots of people, managers very often bear the brunt of this and the brunt of the responsibility. As one leader of a GP's practice said, there was no help or guidance. Suddenly I was in charge of everyone's feelings and expected to carry on as normal. So, you know, lacking support from the managers themselves. Another key action here is to identify people who are too distressed to keep on working, because that can clearly have a negative impact on not only themselves, but patient care, and encouraging them to take time out, even though they may not necessarily want to do that or recognize that they need to do that. Assessing the staffing situation, both immediately and over the longer term, as we'll see a bit later. Reallocating work wherever needed and finding cover if required. Now, obviously cover is often needed externally. So, you know, that can be a very important issue. Identifying also at this stage what can be done to support staff now and in the future. And although very, very early days, liaising with the family if appropriate. And this continued communication channels with the family is very important also in coming days and months. The first week, now the key issues, the key actions needed during the first week relates to continuing communication, coordination of breaking the news, etc., and passing on information, and also ensuring that the staff members have continuing support. And as David just said, purely finding out which bodies to inform was impossible. And even if you did find out who should know, how you actually make contact. So as Fazana said in the interview, you know, she didn't know what to who to tell, didn't know the procedures, maybe people didn't know, maybe nobody knows, which is very worrying indeed. Also deciding what to say to patients, and our interviewees were very keen to emphasize the need to involve all staff members, not just clinical members of staff, but receptionists, etc. as well. Because of course receptionists have a key role also in talking to patients. Informing patients, dealing with their distress, deciding if anybody actually needs additional support, what you actually say to patients, what the family would like you to say to patients as well. And sometimes if you're not sure of the family's wishes, you have to be very careful about how to impart that information. Continuing that staff members are supported, and again, continuing to find time and space for this if needed. And also identifying people who are struggling in particular. And it may not necessarily be the obvious people, the closer friends, etc., who may be struggling. Very importantly is nominating somebody to liaise with the family about funeral arrangements and also passing on that information. Some families may welcome all colleagues and also patients to the funeral, whereas others may want the funeral to be more private and closed. But certainly one thing that we found from our interviews and discussions was that one of the things that was most helpful in helping people come to terms with, or you know, even process the loss of a colleague, is being able to attend the funeral. So that was very important, but it was a problem where people were not able to do so. Maybe because they didn't have permission to close for the funeral and were obliged to make sure that, you know, there was sufficient staff members to make sure there was business as usual. So only a few colleagues were able to attend. So that was a particularly important issue. Dealing with personal belongings also, making sure that, and that's obviously can be a very emotional thing, but it's often needed if you are going to be having to use the working space, etc. That can be quite challenging, and making sure that the family members have these personal belongings. And particularly important during this time is to provide a memorial. Now, this memorial may be a private thing between staff members, but also having something in reception, like a poster with a photograph of the person who has died, and also making a condolence book available. And this condolence group can be a great source of comfort for colleagues and also for family members if you present it to them afterwards. And things like putting flowers in the colleagues' room or on reception. So all of these things can be very, very helpful. What about the first month? Now, the key actions here are getting the right kinds of support, because people often process things in different ways and need support at different times. They have different emotional reactions. But a very key challenge at this stage is assessing risks to the short and longer term functioning of the practice. And as Fazana said in her interview, if you're a single-handed GP, who's going to do the work? She had a medical certificate, but she tore it up because she had to continue to work because nobody else was available to do it. Ensuring continued opportunities for mutual support, but also recognizing that you need an individualized rather than a collective approach. Indeed, some teams may manage it between themselves. People who have a functional team, and we do a good job of supporting each other, which is another quote. But of course, it's particularly important to identify and understand that people will respond in different ways, and people may respond with anger, where, quote here, some team members were angry with the partners for not being supportive and seeming remote, or guilt. This feeling that, you know, particularly as a member of the helping professions, you should have noticed. You should have done something, but you didn't. And you know, this very strong feeling of guilt can manifest itself over the longer term. Very important also to refer anybody with protracted, more serious distress for external support with their permission, clearly, if that is needed. And agreeing a consistent approach to ongoing communications with patients. Now, as Rebecca said, sometimes partners may differ in the approach that should be taken, but the importance of agreeing a consistent approach should be emphasized. And the final quote here, the family were consulted and they did want the practice to be open about the cause of death and also the tragedy of it, so that the risk and the struggle of depression was better understood. Moving on now to the longer term. Now, the longer term is probably stretches out to a year, at least a year, and even after that as well. So a long-term strategy is quite important. So the key actions are really to ensure that people are vigilant, that there are continued opportunities for support here, and there are opportunities for remembrance of the colleague that has died. Again, the importance of support meeting individual needs. But I think particularly vital at this stage is having an awareness of how distress can manifest itself over the longer term and these vulnerability factors that could actually exacerbate the risks of this additional stress. So these factors may be stress from work, burnout, etc., problems in personal life, health problems, people who have limited support networks to talk about, you know, to be able to process this information. And particularly a prior bereavement by suicide can be another risk factor. People may also manifest their distress in behavioral ways, like taking time off sick, problem drinking, or by being negative, cynical, or withdrawing themselves emotionally from people. And it's also quite common for people to work long hours as a source of distraction, you know, so they don't have to think about loss and distress. And another key issue at this stage is to balance the loss with this need to get back to normal. Now, this can be challenging because people recover and process at different speeds in different ways. So trying to do this too quickly can be problematic. But, you know, there is a need, obviously, to restore a semblance of order. Again, very importantly, and this is something that healthcare professionals have a major problem with, is self-compassion and self-care. They often prioritize the needs of patients and other people before their own. But the whole thing, you know, the need to express the importance of self-compassion and self-care for everyone, including leaders, cannot be overestimated at this stage. And finally, deciding how to remember the colleague. And again, having input from all staff and family if appropriate. And I think this final quote on this slide is very, very telling, in that this particular event was involving not only members of staff who could pay tribute to their friend, to a doctor and a colleague, you know, different aspects, different facets of their life. But also family members were there, her husband, talked about what the practice had meant to his wife, and also talked about the tragedy of depression. Members of the team read out tributes from the condolence book, you know, emphasizing the importance of these condolence messages from patients and colleagues, and, you know, people organized flowers and refreshments. And that was a great source of comfort for many people. So to conclude, somebody that I interviewed said this, and I thought it was just such a wonderful, appropriate, short message, in that what we really need is the right person at the right time in the right place. And that kind of sums it up. But of course, unfortunately, a lack of guidance forced staff to improvise, as you've seen, potentially intensifying the negative effects, not only for leaders and managers, but also for staff members in the practice. And we have tried here to offer a flexible framework. Now, people don't have to follow this slavishly at all. It can be very flexible, certainly, and it highlights the key actions and support that are likely to be needed at different stages. And as another one of the people that we interviewed said, what we really needed was somebody to put their arm around the practice at this very challenging time. And overwhelmingly, more input was thought to be needed from external bodies. So first of all, a coordinator to oversee the support and guidance that's needed. So an individual or a team to provide a personal service to the practice during this time. Practical support also, particularly during the early stages, to arrange locums and also to arrange access to crisis funding to pay for any additional staffing costs. Emotional support is obviously very important at an individual level if that is needed. So a helpline and one-to-one individual counselling is also very important. Certainly a number of people we spoke to emphasised the need to talk to people who've had a similar experience, and they really struggled to do that. So a national mentorship scheme is likely to be very helpful to allow people to do that. And finally, a support group that encourages open and honest discussion, where people can just, you know, be very honest about their experiences and their feelings. And as somebody said, I needed to talk to somebody who had been through a similar experience, but of course nobody talks about these things. So you've got nowhere to go. It makes you realize that there isn't very much support available at all. No network to help us during these challenging times. So I'm just going to leave you now with a final quote, again a very powerful quote. There are clear-cut protocols for emergency situations, such as if our phone lines go down, there's an electrical failure, or if a building gets flooded. There should be a recognition that when you have somebody dying by suicide, this is a major incident and it needs to be treated as such. Thank you very much.
Thanks very much, Gail. That's a very clear presentation, very professional as usual, and some food for thought. I can see on the chat some resources. Business in the community have done a brilliant resource with Public Health England. Louise Aston is here and has put that up, so have a look at that. And also, there's also a resource from Cheryl Samuels, who sadly had to leave at 4, from the NHS. But I'm aware that Rebecca's got a comment on that. So Rebecca, would you like to just do a quick comment?
Yes, thank you for those resources, and it will be helpful to add them to those listed. There is a problem in that we have no external or senior management structure. They mention employer, they mention senior management. The people who are trying to manage the practice after a death by suicide are very often the people who are also most bereaved by it, but are still having to take the leadership role. And that is one of the things that was expressed a number of times in the interviews, that people are looked to for leadership and expect themselves to provide the leadership and don't have the support they need to deal with their own bereavement while also trying to lead. It's one of the dilemmas we identified.
Thanks very much, Rebecca. Okay, so any comments on Rebecca's presentation? You're welcome to put it on chat, or if anyone wants to specifically make a comment. It's Laura Finley, welcome. So do you have a question, Laura?
Thank you. Yes, I mean, I've read the report previously and I'm incredibly impressed with it, and it plugs a huge gap. I wondered what you'd found over the very real problem of sometimes discovering that you've got a colleague who's taken their own life and you've got a waiting room of patients there already and more arriving at the door. And the need to be able to tell them that there's been a tragedy in the practice, and would those who really could be seen another day come back tomorrow, or make another appointment as from tomorrow, but actually just to clear that backlog and that pressure of patients arriving into a surgery which is just completely knocked over with their own shock. I mean, they're often in shock before they've even got to grief, and yet they've still got this group of people coming with what will seem ever more trivial quite often and really difficult. And I just wondered what you'd had about coming back, about either just putting a notice on the door or just walking into the waiting room and dealing with that very immediate sort of almost first 10 minutes of realizing what's happened.
Rebecca, do you want to respond to that? And Gail, maybe there's another question as well. So Gail, do you have a comment? And it's great to see you here as well, Claire Gerardo. Thank you for joining us. Rebecca?
Yes, in a sense, that's almost, that's almost the easy bit, because you've had a death and you can say to the people in the waiting room, someone has died. We don't know much about it yet, but the news has got to be broken. So I think that's the easier bit. It's slightly later that it becomes impossible. It depends on the size of the practice, obviously. But there is also the counter pressure that we're not permitted to just close the practice. So we have to do something. I think, Laura, you didn't hear some of the extract that was played, which was an interview with someone who was left single-handed, and it was impossible. So, yeah, again, it's the most bereaved person, or one of the most bereaved people, often the senior partner or the practice manager, who have to make these decisions. And I don't think there is a template. Enough said, Gail.
I can't really comment easily on that, having not been in that situation, I think, and not being a medical practitioner or GP myself. I just can't imagine the stress and the difficulty of reacting to that. if that makes sense. I think certainly it does depend on the number of people that you have available and how they are affected in the short term. But clearly it would very much depend on the circumstances also, and the ability also, you know, to ensure that you are continuing with care and delivering care as appropriate, whilst making sure that your staff members are processing the information. But it's very, very difficult. Yeah.
Thanks, Laura. I'm going to move. I've got 2 questions I want to cover. So one is introducing Emma, who I think has got a question, and I've got also a hand up from, I think it was Ivan. So over to you, Emma, quickly first. Thanks.
Yeah, thank you. Welcome. My name's Emma Wade. I'm the head of mental health nursing for NHS England and Improvement. And I'm leading a piece of work at the moment around supporting nurses who are also very high risk of suicide. And what's come up, specifically, I guess, a light has been shone on it through COVID. That trauma around losing a colleague, particularly if you've been someone working alongside or caring and didn't notice, but also how that then leads to their own suicidal thoughts. And I was just reflecting on that and my own PhD research, which also was a grounded theory, so a qualitative study of adults bereaved by adult children. And it was very similar. What I was really struck by was all of them had subsequently had thoughts around suicide, and several had attempted to take their own lives. So I guess it was just a reflection on the increased suicide risk once someone has been bereaved, that can then be for some time afterwards, and factoring that in around support. So I found your guidance really helpful because, surprisingly or not, we don't have anything similar in the wider NHS either on how we might support or manage, or even indeed recognise or know when a colleague has died by suicide. It's not currently recorded anywhere. So organisations are often left to manage themselves. So your guidance is greatly helpful to shape that. And my other comment was observation was linked to around the memorial aspect and how significantly important that was to all the families I spoke to. And of course, again, COVID has cruelly snatched that opportunity away, because actually what was a great source of comfort was that ability to publicly say goodbye and to come together and reflect and to listen and share memories. And of course, that's been made almost impossible beyond that close family, which can often leave colleagues feeling that there isn't a place for them to share those memories and thoughts and have that closure. So it was just an observation how COVID, I suppose, has kind of shifted how we might grieve and the impact that might have going forward.
Yeah, thanks. That's really helpful. I'm going to take the chair's prerogative, and I'm going to just say that I'm sure Claire Gerarda, who's put a useful comment in the chat about support for the Royal College of Psychiatry for people who've lost people from suicide. So I'm sure Claire and Lucy will cover that in the next session. I just want to give last minute Dr. Ivan a quick opportunity to put a question. I'll hand over to you, Claire, I suppose, in the first instance. So Ivan.
Thank you. So I have personal experience of this in that my neighbouring practice, the senior partner there, his wife, who wasn't a GP but a practice and is very close to my wife, basically walked into the River Dee and committed suicide. And this happened on a working day. And the GP there, Neil, we were all devastated and nobody knew what to do. We told the patients that what had happened, and obviously Neil couldn't be in the surgery, and I covered his surgery for him. So and the PCT in those days, so this is going back quite a number of years, was incredibly supportive and helpful. And somehow we muddled through the day, and on the funeral day and subsequent days, it was hard, but we managed it. And on another occasion, and this was a GP. He didn't commit suicide. He actually died of an epileptic fit at night. And in the morning, we had to tell the patients, this is again in a neighbouring practice, that Dr. Morgan had passed away. And patients were very understanding and supportive, and they all sort of kind of walked away. In my role as an LMC secretary for Mid Mersey, I've had the opportunity of supporting a practice in Knowsley where this GP tried to commit suicide, wasn't successful, was admitted to hospital and basically hung himself. And we had to inform the patients within the practice and support the other GPs in the practice. It was traumatic. It was awful. But what I did find in all this was how incredibly supportive patients are and how incredibly understanding people are, irrespective of what they do, whether they be in the PCT or now in the CCG or in NHS England. But everyone, including the cleaner, the pharmacist, the receptionist, everyone. And you know, it is really moving and humbling to see how humanity comes around and sort of hugs you when the bad.
Okay, I mean, thanks. I'm sorry to stop you short, and I know, I mean, you're right. You're so right. It's all about that kind of humanity and compassion, and but hopefully it's always there. But sometimes, sadly, it's not. All the structures aren't in place. So I'm going to hand over now for 5 minutes response or from practitioner health. So Claire Gerarda and Lucy Warner, because we really do need to understand what NHS practitioner health offers. So over to you, Claire and Lucy. Thanks.
And I'll let Lucy cover practitioner health. What I'm just going to talk about is the group that I run for those who have been bereaved following the suicide of doctors, dentists, medical students, any health professional really, which I've been running for 2 years, and some members of the group and this Zoom call have been to my group. It's, as you've been hearing, the suicide of a doctor in particular is very complex. Not least the fact, and I know, Ivan, you said that society hugs the bereaved. They don't actually. If the bereaved is actually a doctor, a psychiatrist, a nurse, what tends to happen is that it's much more complex. And if you go to, it's much more complex because not only has the person who's killed themselves done something which is still quite a shock, which is taken their own life. But here is a doctor who should be healing people and not killing themselves. And if the bereaved person left behind also comes from the medical profession, they are left with all sorts of unanswered questions, usually hinging around, why didn't I notice it? Why, if I'm a doctor, didn't I pick up the telltale signs? So it is much more complex. And also, if somebody does die through suicide, there tends to be blame attributed, and it tends to be the blame is put upon the psychiatrist, the GP, etc. So it is a complex space, and the reason I set up the group is that these people who were bereaved were floundering in other spaces, not always, but were floundering in other spaces, and were essentially picking up the projections of people that, you know, doctors shouldn't kill themselves, and therefore as a relative of a doctor, how on earth did you let it happen? And if you were a doctor yourself, how on earth, you know, didn't you pick it up? I'm not saying that they should have, but that tends to be what the projections are. And you also tend to get the business as usual. So I'm struck by Rebecca, you know, the fact that you've set this up, and but the practice, yeah, they can't shut, but they should shut. There's no can't, they should. And yet, because doctors, especially GPs, I hasten to add, feel that they're somehow invincible, somehow need to manage everybody else's pain, including the patient's pain, ignore their own needs to the extent that they want to support the patient of the dead person, rather than supporting themselves. And whatever it is, you as a partner, as a colleague, will have had a far closer relationship with the dead person than any of the patients will have had. So the bereavement group has been running now for over 2 years. It runs once a month now on Zoom. When and if we ever go back to face-to-face, it will run once a quarter for 3 quarters of a day. And if anybody knows of anybody wants to attend, or anybody here wants to attend, just contact me through PHP. I have written a paper about it called Groups for the Dead, which I'm very happy to circulate at some point. So really that's all I'm going to say, and hand over now to Lucy. Sorry about the telephone call.
Thanks, Claire. And thank you so much to the Louise Tebboth Foundation for inviting us both to participate in preparing the guidance and to speak today. and an opportunity really just to tell you about what PHP is, if you don't already know, and the ways that we might be able to help in a situation like this. So I'm hoping by now, 12 years on, most people do know what practitioner health is, but for anyone who isn't aware, we're a service England-wide, available to any doctor and any dentist, if you do have colleagues who are dentists, to provide mental health treatment. And we're completely confidential. We're embedded in the NHS, but we're not part of the NHS spine, and nothing that sort of comes through to our service will be shared without the consent and the knowledge of the doctor who comes and accesses that service. I want to talk then about sort of Louise, because Louise was a patient of our service, and sadly she was a patient that we lost, and we have lost around one patient a year to suicide in the time that we've been in place. And each of those deaths really does hit us as a team. And we ourselves, we need time to reflect, we need space to talk about that person, about what they meant to us. Because those people, they are not only colleagues, but they're people that we come to care about very much. And so for us, you know, this advice and this guidance that you've produced is as important for us in a way to be thinking about kind of how we support one another within practitioner health when we lose somebody, when we lose a patient of ours to suicide. And that's why we think it's so important what you've done here. Because clearly when you lose somebody, it's like losing somebody who's as close as family, who've become such a part of our lives really, in terms of our working lives. So I want to talk about what PHP might be able to do to help in a situation like this. And Claire, of course, has talked about the bereavement group, and she didn't mention, but the next bereavement group is actually this coming Friday. So, you know, if you do know of anybody, please do make them aware. And it's really important that we connect with as many families as possible. I think there's about 40 families who are now part of that group and who share those kind of words of wisdom and that comfort in times of need. People at different stages of their journey with different experiences. And I think they even, when they can meet face to face, I think Claire tells me they often share cake as well, which I think is completely sort of important and really probably needed in those times. But then I want to talk about the partners in the practice and the leaders in that practice, because you've mentioned sort of the responsibilities that are sitting on their shoulders. And I think that's where PHP really can come into play. And we can provide that one-to-one support, that they can access a lead clinician, they can access therapy, they can access medication, they can be signed off sick. I take the comments earlier about who do you actually give the sick note to, but legitimately if you've got a sick note, then you can get the CCG to step in and provide some cover and provide some support if you happen to be a small practice and you just can't deal with what's going on. So we can provide all of that period of support. And for many people, they may not be realising they need it. And lots of people who access our service say, oh, I don't really think I'm sick enough. I'm not really ill enough. I'm probably not bad enough for your service. And the one thing we would say to everybody who's experiencing this type of situation, try us out, see if there's something we can offer. We may be able to help, you never know. And if nothing else, we may be able to connect you into something like the bereavement group. And then the next thing I'd like to mention is the memory list that we hold. Because the one thing I think that we have to hold dear when we lose any doctor or any health professional to suicide is remembering their vocation as a clinician and their commitment to care for others. And so our memory list really is a time for us to sort of collate those details, remember those people as the caring clinicians that they were, remembering what it was that they came into medicine for, what their dreams and their hopes were. And we collect this list and we collect all of the details around that person. And next year, when it comes to the International Conference on Physician Health, we're planning to work with that list and hold a memorial type moment for those doctors and those other health professionals that we've lost. And that list covers many, many years. It goes back in some cases sort of some 15, 20 years, but also includes people that we've lost in very recent weeks. So it's an important list for us to hold, and it's important for us to remember those people. And we're not aware of any other organisation or team that's doing that. And then finally, I know that, you know, this team around the doctor who's been lost will need support as well. And the other thing I guess that practitioner health can do is we have access to an amazing team of therapists and facilitators and links with organisations who can provide that support. So we really can help signpost people and help them provide that support both to the team as a whole and to individuals where they need it. So you know, please remember, pass on the word. If there's one thing you can do for us and for doctors who may be lost to suicide, is make sure people know about practitioner health. They know how to access us. Our website's very, very simple, practitionerhealth.nhs.uk, and all of our contact details are on there. If anybody wants leaflets, cards, you can stick in your wallet and pass to somebody that you think might be in need, please just get in touch and we can send those out to you. So thank you so much.
Thanks very much, Lucy, and thanks, Claire. That's really, really helpful, and well done for all the work you do. It's very much appreciated. Okay, we're entering the last half hour. Just to remind people what's going to happen. So I'm going to invite Gary, who's secretary and founder of the Louise Tebboth Foundation, to say a few words. Hopefully, Martin Marshall, I can see you're here on this, can also respond from the RCGP, and then David Wrigley from BMA. Then we've got a bit of time for further discussion, questions. Alex, Rebecca, Claire and David, welcome to contribute to that. Then over to Baroness Laura Finlay for final reflection, and then a very lovely and powerful video from the Louise Tebboth Foundation to close. So that's the last half an hour. Definitely, you know, it's brilliant seeing it. We've got at least 50 people on this call and everyone's staying. So, you know, it's fantastic. So Gary, over to you.
Thanks very much, Nick. With some impeccable timing, I'm afraid there's some drilling next door, so I hope that doesn't interfere too much with what I'm about to say. Just a few words, really, to say that I'm humbled and I'm very proud to think that the Louise Tebboth Foundation has had this opportunity to commission and fund another groundbreaking piece of research in the field of the suicide of medical professionals. And for me personally, it always helps ensure that Louise can continue to do what she always wanted to do more than anything else, which was to reach out and help people. And I think it's particularly appropriate that in this case, it's her colleagues in primary care that this piece of work is looking to support. Louise cared passionately about the mental and physical well-being of her colleagues, clinical and non-clinical staff alike, just as she cared deeply about the wider health system. And she'd be the first to appreciate the value of a framework of this nature, because the suicide of a health professional is a relatively infrequent occurrence. Sadly, not infrequent enough. Colleagues who encounter it are unlikely to have any direct personal experience on which they can draw. And until now, we know that there's been no real reference point for those who are left behind, no how-to manual that they can turn to for guidance. And obviously, I very well and vividly and graphically recall those early blurred days and weeks after Louise's death. But even in my own anguish in that time, I could see the profound impact it also had on her colleagues and her patients, and how much the practice had to work through in order to judge how best to respond. And I know that they eventually found a way, just as I did in my personal journey. And in fact, I think the fact that the family and the practice worked hard to help each other is something that we can both be proud of. And in this, I think we were assisted enormously by the fact that we had pre-existing relationships. We knew each other. We'd been to dinner parties, we'd been to picnics, we'd been to housewarming events. So that certainly helped. But I'm sure that a framework like this, which draws on experience and best practice, will be enormously helpful to those practices and by extension the bereaved families who are sadly going to have to undertake that same journey in time to come. And I'm especially glad to see recommendations for the establishment of support groups for colleagues affected by a loss of this type. I know from my own experience how valuable peer support groups for bereaved relatives, such as the one that Claire and Lucy have run through PHP, can be. And sometimes the most important thing of all is just to be able to get away from it and just to spend some time with people who truly get it and to understand what you're going through and are able to offer the benefit of their own experiences. Just to end, some thanks in particular to Gail and Rebecca for their their energy and commitment in the research and drafting of the paper. Reading it through again last night, I was really struck by its clarity and its practicality. And thanks to Nick and the Society of Occupational Medicine for collaborating with us on the project, and also for facilitating this event today. Thanks very much, Nick.
Thanks, Gary. I remember very clearly when you came to see us, and you've done some brilliant work. So well done, Louise Tebboth Foundation, and your role founding it. It's fantastic. Okay, Martin Marshall, hopefully you can, from the Royal College of GPs and then the BMA, it'd be great to get your response to what you've heard so far.
Yes, thanks. Thanks very much, Nick, and thanks to everyone for contributing to such an important piece of work and such a stimulating webinar this afternoon. When things go well, being a GP is the most brilliant job in the world. It's the most privileged, the most rewarding, the most stimulating. But we all know it can also be the most challenging, the most stressful, and at times the most painful job as well. And it isn't surprising that GPs suffer sometimes, and sometimes that suffering can be overwhelming. The death of a colleague by suicide is probably one of the most challenging and distressing events a practice team can possibly experience. I'm fortunate that I've never personally experienced a loss of a colleague by suicide, but I've got several friends and colleagues who have done so, and I'm aware of what they've been through. I'm also aware that without external support, as Gail said, without someone to put an arm around the practice, the effects on the practice team can be devastating and long-lasting. The grief, the anger, and the guilt, as David described, that people feel is very deep and very real. Help is desperately needed. So as a college, I really want to sincerely thank the Louise Tebboth Foundation and the Society for Occupational Medicine for developing such a comprehensive and compassionate, and probably most importantly, such a practical resource to support practices to respond to the death of by suicide of a colleague. As a college representing 54,000 GPs around the UK, we welcome the new framework, and we will work with others to ensure that it's made widely available. We'll also ensure that the report findings are aligned with the work that the college is doing itself to support the well-being of people who work in general practice, including our early intervention programme, our practice support team headed up by Pauline Foreman, who's also on this Zoom call, which is doing amazing work with practices struggling to cope with a currently highly challenging environment that we're all working in. So thank you, and well done to everybody. This is such an important resource. Thank you.
Thanks, Martin. That's nicely said, and it's great to have the backing of the Royal College GPs, and we had a very good meeting also with Jonathan Leach about occupational health generally, so it's great to have that support, and also well done, Pauline. It must be very difficult dealing with GPs needs at this difficult time, so thank you. So David Wrigley from the BMA, I hope you're there as well to offer some...
yeah, thanks Nick, and thanks for asking me to speak. I'm David Wrigley, I'm a GP in Lancashire. I'm Deputy Chair of BMA Council. So the BMA is the doctors' trade union. We've got over 160,000 members, but we're also a professional organisation, and we look at issues in medical ethics. We have a board of science, and we look at really important issues like this with our wellbeing work that we do. This is an issue quite close to my heart. Before I was a medical student, I had a working life in Blackpool, and I was a volunteer for the Samaritans for 5 years, and that gave me an insight, you know, non-medical, non-judgmental listening voice to those at the most desperate time of their life. And it's an important role, I feel, in society that we have Samaritans all over the country and organisations, so I would encourage you to support them, because they do play a very important role, particularly nowadays when mental health is under such stress. And we know that doctors want an NHS that has a culture not rooted in blame, you know, one that supports and encourages learning and celebrates diversity. But the government have a role here in supporting doctors, so organisational protocols that respond to the deaths by suicide. And your paper today is a very important step in that. That checklist is invaluable, actually. And actually a collation and annual reporting of statistics is really important as well, because we know in doctors there's a real stigma over mental health and not disclosing it, suffering in silence, and this just exacerbates the problems, because we know that doctors just battle on, they carry on caring for others and don't prioritise their own health, and that's just a slippery slope. This year obviously has been really difficult for the profession. We undertook a fortnightly tracker survey of our members, and each one had well over 10,000 replies, which was quite incredible really, and that allowed us to take the temperature of colleagues during the COVID crisis. And we know that from that, over half of the doctors responding were suffering from depression, anxiety, stress, burnout and other mental health issues, and 35% of them said that it got worse during the pandemic. And also worryingly, 22% didn't have any access to support. So that is a real concern for colleagues. And also our BAME colleagues were more likely not to seek support as well. So the BMA has a wellbeing support line that's open actually to all doctors. You don't have to be a BMA member. It's 24/7. It's open to medical students as well. And we've actually extended that this year to all partners and family members of doctors and medical students. And we've seen a 40% increase in use of that helpline during the pandemic. And that's a really worrying statistic. And you know, that line will listen to people, support them. It will offer them structured follow-up, peer-to-peer support, and then ongoing therapy if needed. So it's a really vital support line there, and I'd encourage you to pass the information on there. So just to finish off, going forward, I mean, I know Alex very well. We've known each other for 20 years at the BMA, and I intend to have further conversations with Alex about the work she's doing with the foundation, involving our GP committee as well, which has representatives across the UK, and how to take this forward. And of course then developing our wellbeing offer, which we have a wellbeing support group that actually meets next week, and that brings together all the agencies involved in this arena, and we'll have well over 30 attendees next week to see how we can take issues like this forward. So thank you for all you're doing. Thank you for asking me to speak, and I wish you all the best for the future. Thank you.
Thanks very much. Yeah, it's really fantastic what the BMA is doing and RCGP, and creating that sort of culture change so that we don't get the situations happened with Louise's sort of practice in the aftermath. Now we've got a time for discussion with the panel. You know, Martin, Gary, David, welcome to sort of join Alex, Rebecca, Claire and David. But, you know, I'm particularly interested in the new voices, people who who've been invited today, who've got things to share in terms of their experience or concerns. So it's nice to have that open sort of discussion. So I'll just leave it open just for a second to hear what people have got to say. Okay, well that's I need to give people some time to reflect. Alex, or people from Louise Tebboth Foundation, I mean, what's your reflection on how the BMA and RCGP are stepping up in this?
Yeah, I mean, it's really refreshing to hear such support from these national organisations, and David's talked about some of the wellbeing work that the BMA has been doing. They've been doing that for 20 years, and it's grown and expanded, and also the college and the work that they're doing in the professional support and other things is incredibly welcome. And I think that in practice, in general practice, I'm a GP myself, is that you often forget that these big organisations actually are there. And I think what struck me about the initial aftermath in the report was just that people were not aware that these types of support existed, and I think anything that we can do in awareness raising in terms of who is actually out there, as I said, that one of our participants said, have a major incident plan. Well, this is exactly the sort of stuff that should go in your major incident plan. So it's really welcoming, and I certainly I know that Rebecca and I are very keen on forging improved and strengthened links with both RCGP and with BMA, and to see how they and other organisations can take this work forwards.
Thanks, Alex. I'm just looking at the chat, and actually, I'm noticed that doctors in distress are here. It'd be good to hear from them. And also, Doctors Mess has talked about small facilitated groups, so it'd be good to hear about that. And then Ruth Riley talking about the study for nurses. So that's on the chat from Birmingham.
Nick, can I bring in Amandip then from Doctors in Distress?
Yeah, go on. Yeah.
Amandip, are you here? I see your name.
Yep. Hi, Claire. I'm here.
Hi. Amandip and myself run a charity called Doctors in Distress. I'm the chair. Amandip, do you want to just say a few words about your experience?
Yeah, thanks. And first of all, thanks everyone for this call. So I started off the charity last year in 2019, and I lost my older brother, Dr. Jagdeep Sidhu, who was a consultant cardiologist, to suicide in November 2018. Like many of the themes here, it's something that affected me and my family, friends, colleagues, patients particularly, as well as something that's completely unexpected. And I realized very, very quickly that he was obviously not alone in this very, very sad phenomenon. So I wanted to create, I guess, an entity, a platform, a springboard, whatever definition you want to put on it, to help raise awareness of issues such as doctor suicide particularly. And I linked up with Claire earlier this year, and we've made some great progress, but I'll maybe just hand it back to Claire to maybe talk a little bit through that first.
Well, just briefly, our aim is to reduce suicide and to reduce stigma around doctors' mental illness, but we're doing it through creating reflective practice groups of whatever sort. It can be anything. The rule is that it's a space, a confidential space, where health professionals can come together to talk about the emotional impact of their work. And we've started already. We supported the stranded doctors. We're just about to start a group for long COVID, for doctors who've got long COVID. And we're a new charity. We're raising money, but please look at our website, and if you feel that either yourselves or others want to put together a support group, we can help fund that and help provide the infrastructure.
Thanks very much, Claire. Okay, we've got a couple of minutes before I hand over to Laura Finney. So just wanted to give a floor to Rebecca Viney, talking about work on Doctors Mess. Rebecca, you there?
Yeah, Ruth Riley. So that's all right. So we're aiming to build on what has been done here today. I should say, because of the funding cycle, it takes about 18 months to get National Institute for Health Research funding. So we're not duplicating what has been done. It's just the unfortunate timing of it. But the focus of our study is looking at the impacts and support needs of nurses, doctors and paramedics and suicide. And originally we were going to focus on community settings, so GP practices. But I think the bulk of our focus now, because there's no point in reinventing what Gail and Rebecca have already done. So I think the focus of our energies will be looking at hospitals and the ambulance service, because male paramedics have high suicide rates, as do nurses.
Okay, sorry, I'm going to kind of rush you, Ruth. Apologies for that. Just in the last minute, I mean, it's good to hear that, and do tie up with Gail. I did get my R's mixed up in my scrambled brain. So Rebecca Viney, also I wanted just to give a minute to before we hand over to Laura. But thanks, Ruth. That's good to hear, and it's good to make those connections. So Rebecca.
Hello, and thank you. Can you hear me?
Yeah, yeah.
Great, good. I wasn't expecting to speak. I was going to listen, but I'm always happy to invite anybody who would like to come to the Doctor's Mess. It's a safe place. It's for well-being. It's to celebrate the fact that healthy doctors, mentally and physically, are with good well-being for themselves, will be much more effective doctors, and there's loads of evidence about that. And so never has that been more important that we put the oxygen mask on us first. And kindness is our byword. and compassion and confidentiality, so people can come for one-to-one or small group with fabulous facilitators, all of whom, as well as being educators, are coaches, so they will train people to find their own solutions, not give advice. And it's great fun, and I miss it when I'm not there.
Thanks very much, Rebecca. That's it's lovely to hear, and I'm sure that's huge value. Okay, so I'm going to hand over to Laura Finley, who's going to just do a reflective summary for a few minutes, and then we're going to play a video from the Louise Tebboth Foundation. I mean, the Louise Tebboth Foundation is a charity, and I would encourage people who want to support it to do so. It's been a really moving afternoon. Again, look after yourselves, and there are resources there like Mind and Samaritans if you're feeling distressed yourself. But I'm going to hand over to Laura now. Thanks, Laura.
Thank you so much. I think, like everybody on this call, one way or another, we've all been affected and hit sideways by the sudden, unexpected death by suicide of somebody who was important to us. This piece of work, though, that Gail and Rebecca have done, I do think is exceptional and incredibly important. It provides a framework, and as I read this through, I felt that very clear, very simple, straightforward framework, dividing up immediately and then later on, and the way that it's sequenced is a fantastic resource. I hope that it will also be available to dentists and to vets who are also at very high risk in very much the same way, and that more and more people could really access this. I hope that the RCGP would be able to adopt that framework, and the BMA adopt it and make it really available to all of those smaller and more distant practices who perhaps don't have the networks, who aren't as up to date as others, and who are in far-flung areas where it may be harder for them to call for help for one reason or another, when they're early on or when they're suddenly faced with tragedy. I also think that that framework actually is so amazingly applicable to any sudden death. So the sudden death of a child, of a member in the practice, or whoever, and I commend you for that work. I think it just shows how important the foundation is and how important it will be going forwards. And in these times of increasing unemployment looming, and we all know the effect of unemployment on mental health, I think this work is going to become more important than ever, actually. So I feel very privileged to have been part of this afternoon and to be part of the foundation. Thank you so much.
Thanks, Laura. Okay, thanks to everyone. We're going to move to a video now about Louise. Thank you all for attending. We'll send around details afterwards, and also people who couldn't make it. It's been very, very good, and I just hope we get really that situation where this doesn't happen anymore, where practices just get thrown into disarray and emotionally it's so upsetting. So have a look at this video. Do support Louise Tebboth Foundation. Thanks to the BMA, RCGP, and everyone from Louise Tebboth Foundation, and Gail as well for writing the paper. And let us keep the progress. Thanks to Claire, Doctors in Distress, and everyone else who does that. And here we go with the video. It's really worth seeing. So just hold on, and thank you, and have a good evening, everyone. Bye.
We all got together and we tried to remember the best of her. I just thought, let me just go on the internet, see what the world knows about Louise. We found in every single feedback left for Louise was one of such joy and such splendor that, one mentioned that she should be cloned to make benefit for the future of the NHS.
To a wonderful, caring doctor who I will remember forever, who was incredibly kind and thoughtful. I will never forget her smile and attention she put across to me. Her calm and patient approach was always welcome.
Thank you for being ever smiling, considerate and professional at all times. Louise, you will be greatly missed.
Dr. Tebboth was a wonderful doctor and person, always understanding and sympathetic. She was wonderful with my eldest daughter and diagnosed with cancer.
Louise, thank you for your support and help through the times I was down. I left the surgery feeling lifted.
I met Louise when she was assigned as my son's doctor. He was born prematurely. She was great with him and always listened when I brought him in.
Louise, you will be greatly missed.
Louise was a wonderful doctor and a kind and compassionate woman. She always listened with patience and love.
Louise was an outstanding doctor, perhaps especially to those who were struggling. She was so effective because she really understood.
Louise fought against depression with extraordinary strength and determination for many years, managing mostly to remain well. But in the second half of 2014, she suffered a particularly severe attack. After many ups and downs over several months, she seemed close to beating the illness again before she crashed for the last time, after being advised that she was not quite ready to return to the work she loved. Louise loved her job. It gave her so much satisfaction and meaning. She was desperate to return to work as soon as she could. For those who don't understand mental illness and the darkness and the confusion it brings, it can be impossible to comprehend how anybody could possibly believe that their loved ones would be better off without them.